One of the great things about being involved with planning and organising the course is for the specialty day, I get to say, oh, well, I've never really understood this and I want to learn more about that. Or I think this has moved on since when I first learned it, so let's refresh on this. So essentially today is what I want to know about the knee and deformity correction. So I hope it suits your needs as well. So I was asked to do, in with that, just a quick starter on the general principles in children and adults. So I know it's hard to believe, but I went to med school in the 90s. And back then, the knee, it was just a hinge joint. You know, that's all you needed to know about the knee. And MRI scanners were literally only just being brought in to clinical practice. I asked last week in Hull, we first got an MRI scanner installed in 1992. And I remember going down to the X-ray department with the card and begging for ultrasounds and chest X-rays. I don't ever recall requesting an MRI scan as a junior doctor. It's new technology, and with that, the specialty has changed considerably. So when you see somebody with knee pain, it isn't necessarily the first thing you do is get an MRI. And back in the 90s, we used to take a history and examine the patient first. And certainly that's what I would recommend you still do when assessing somebody with knee pain, especially in case you either have a deformity or sometimes you can risk missing something, missing a deformity, which is more relevant when looking at the knee. So everything that you're asking about history, whether it's a deformity, whether it's possibly a deformity, it's all your usual things. I think if you don't specifically ask any previous history of trauma, including surgery, and any suggestion of current or historic infection, they're the things that patients don't always tell you because they don't get that might be important. So make a point of asking that. And then examining the patient, all the usual things you're going to look for. Do not forget the hip. We've all seen patients who their knee pain is actually from the hip, so I'm just reminding you all that now. And don't forget torsional profile, including adults. Don't forget compensatory deformities, including adults, because if you straighten their leg and they've got hindfoot valgus or varus, they're not going to thank you when they can't walk. And looking generally at the gait. And remember, kids are much better at compensating and hiding, but adults, if they've compensated, that compensation is much more likely to be fixed. And then move on to your special tests. Don't forget your long leg standing X-rays. Don't forget your general weight bearing X-rays. We talked earlier in the week about valgus varus stress views. Think about CT and MRI. With all those X-rays and CT, don't forget you are exposing that person to radiation. Again, probably more relevant in kids. And we certainly know from adolescent scoliosis, that is a real lifetime increased risk of cancer. And it does bother me that some of these kids have repeated long leg films and people send the kids for a long leg film before they've even clinically looked at them. You're following up those 8-plate kids. So try and ration and think about that, because I know that there are less internal organs that are X-ray sensitive on the lower limb, but we're still exposing the pelvis to radiation with those images. And if you want the reference, this is from a Danish cohort study. So moving on to MRI. It's expensive, it's time consuming. Some people hate it, they feel claustrophobic, and it can be difficult to get kids in scanners. I generally find from the age of 6, most kids will tolerate it if you explain it to them. And it doesn't hurt, it's boring. I think that's the main message with an MRI scan. And when you first go into it, it can be a bit odd. If a child needs a general anaesthetic for an MRI, I would really, really think, should we be adding gadolinium in? Because then there's nothing worse than I have seen kids present with, for example, fixed knee flexion. You're not sure what's going on, you get an MRI, the MRI is inconclusive, you repeat it with gadolinium and it's a tumour. And so I think if you're going through the process of having a GA, in our hospital, policy now is every child having a GA for an MRI gets SCAD. So if you follow that, then when you see this kid with knee pain, you might recognise that they had a fracture treated in another country and they've got a deformity. You might pick up that this guy broke his tibia, had deep infection, had plastic surgery. You might realise that this girl's got Blount's. Obviously, one of the big differences with kids is they have the physis, which can really be your friend. And we've got a talk later today on growth modulation, and you can use that physis to the best of your advantage to minimise big intervention and the development of significant deformity. It can also be your enemy, especially in fractures around the knee. And this kid who had an open physial injury went on very quickly. This is only 7 months and he's got valgus in that leg. And this girl who seemingly had an anatomic reduction of this fracture early developed leg length discrepancy and didn't present with that until she'd finished growing. So my message there is any knee physis injury, follow to skeletal maturity to make sure you don't miss developing deformity. And when you've done all that, it's back to what we've been doing all week. Make a plan. Just take your time to confirm that your plan is going to help with what the patient's needs are, what their symptoms are. And sometimes in kids, it's confirming that that plan is going to prevent long-term harm. I think that's true in adults as well. Just because you can break the bone and straighten it, does that mean you should? Is that to their advantage? And also consider carefully your timing of intervention. With kids, you can time things to really reduce the impact on schooling. With adults, they might have life events they want to delay it. A lot of this stuff can wait. It doesn't have to be done tomorrow. So in summary, I think the principles are the same for kids and adults. It's history and examination, special tests, make a plan. And any of us who are housekeepers for children know that adults are disadvantaged kids in many ways. I don't have a taxi driver. I don't have somebody cooking my meals. But also, they don't remodel and they don't have a physis. So I think kids can be a bit more forgiving. Thank you.